Muchísimas gracias. Welcome, everyone. I want also to let folks know that ASL interpretation is available, as well as live captioning. So you can put on the live captioning by hitting show subtitle at the bottom of your screen, and you should be able to see captioning there. So we hope that this makes the event more accessible for folks who are attending. We are also recording the event, and we hope to share that with the folks who registered for the event, if not publicly. My name is Andrea Ritchie. I am coming to you from Wawenatanong on Anishinaabe, Odawa, Wyandot, and Potawatomi territory, also known as Detroit. I am a very light-skinned Black woman with curly hair, blue glasses, blue shirt, and I'm sitting in my office/living room with some paintings behind me. I am the co-founder of Interrupting Criminalization, which I co-founded in 2018 with Mariam Kebé, and we wanted to create a container for work that we had both been doing for decades around particularly criminalization of women, girls, queer, and trans people. And we're able to pool our resources and create a container that has since grown tremendously. So other members of our team are Eva Nagao, our creative director, Erin Glasgow, who's running tech today. And if you have any problems with tech, you can direct message them or direct message hosts and panelists. Given the tenor of conversation these days around some of the topics we're discussing, we've disabled the chat for everyone, but if you want to communicate with the hosts and panelists, you can. We also are joined at Interrupting Criminalization by Tiffany Johnson, Tiffany Wang, who, if you found out about today's event on social media, it's because of the work that she does to get the word out. And also by 4 fellows, and one of whom you'll be hearing a lot about tonight and seeing the fruits of her labor tonight, Maria Thomas, who's our Beyond Do No Harm Fellow. We also have Shira Hassan as a Transformative Justice Fellow, who operates our Interrupting Criminalization Help Desk for folks who are trying to build responses to violence in their community or harm or conflict that don't involve the police and increase community well-being and safety. And we were recently joined by 2 more fellows, Louis Raven Wallace, who's a Movement Journalism Fellow, and Maurice Weeks, who is an anti-capitalist abolitionist organizing fellow. So our team has grown mighty, and that's who we are and who is hosting the event tonight. And we are also the hosts and conveners of the larger network known as the Beyond Do No Harm Network. And I just want to celebrate what a momentous occasion tonight is for the network and the over 60 members of the network who are healthcare providers, public health researchers and workers, organizers and advocates in movements for racial, gender, reproductive, economic, migrant, and disability justice, as well as people who have been organizing around drug policy, around the rights and experiences of people in the sex trades, and across many other movements who have come together to make up this network called the Beyond Do No Harm Network. And it is a momentous occasion because what we are releasing tonight and sharing with you and inviting you into with us is the culmination of 3 years of work that I'll describe in just a second. But it also could not come at a more critical time, in a moment where just today, a politician who was a former presidential candidate was calling for the arrest and incarceration of healthcare providers who provide trans and gender affirming healthcare, and a day where There are consistent threats of criminalization to providers offering abortion care, and also to continuing criminalization and ratcheted up and accentuated criminalization of all the people who generally experience criminalization through access to healthcare, including pregnant people, parents, drug users, trans people, gender nonconforming people, migrants, disabled people, people living with HIV, and people in the sex trades, low-income people, poor people. So the criminalization that's happening in the context of access to healthcare is ratcheting up with right-wing agendas, and so we are here to meet that moment. But we didn't just come up with this overnight. As I said, this is the product of 3 years of and many more decades before that, but for interrupting criminalization, 3 years of work that started in 2018, around the time that we formed, when we were thinking through the many places where criminalization of women, queer, and trans people happens. It happens in the same ways that it happens for cis men and heterosexual folks, which is, you know, on the streets and in communities and stop and frisk and profiling and traffic stops and physical violence and police killings. But it also happens in the context of accessing help, whether it's accessing help as a survivor of violence, accessing help in terms of social services, and accessing care in terms of healthcare. And as we were seeing the Trump administration and right-wing administrations and policymakers and legislators across the country advancing agendas that were intent on using criminalization to control sexual, reproductive, and gender autonomy, we thought it would be really important to bring together the experts in the field, the people who have been fighting at these intersections for years, for decades, to think through what are the points at which people are experiencing increasing criminalization of gender, sexual, and reproductive autonomy, and how can people in existing movements intervene to interrupt that as part of a larger fight against right-wing agendas. So we came together in May of 2019. We mapped the ways that we saw criminalization of sexual, gender, and reproductive autonomy happening, and where different movements could intervene, and the larger systems that were driving that criminalization and that needed to be addressed. One of the systems, in addition to policing, prisons, probation, parole, immigration enforcement, and social services, where we saw that criminalization happening, was in the medical industrial complex, in the context of healthcare provision, healthcare distribution, healthcare denial. So we teamed up with Sister Song in the fall of, and I should say before I talk about teaming up with Sister Song, we had partners at the Center for Advancing Innovations in Policy, CAPE, Veronica Bayetti Flores, and Isha Pandit were part of co-conveners of that initial meeting, and also of the fall meeting where we partnered with Sister Song and held a day-long convening in the fall of 2019, this time with over 100 people from the movements I described earlier, to talk about all the ways different populations experience criminalization in the context of accessing care. And people from across those movements came together for a day. And we started the day, as we'll start tonight, grounded in the long history of criminalization of the very same populations in the context of accessing medical care, and the very long history of resistance to criminalization within the larger medical industrial complex, given to us or delivered to us or shared with us by Kara Page, who is a longtime comrade and colleague and teacher and organizer that many of us at Interrupting Criminalization and Beyond have learned from and been in community with over the years, who is also a memory worker, who has found ways of sharing this history and these memories as part of movements to end the criminalization of people seeking healthcare. We started that day in September, grounded by Kara. We'll start tonight, grounded by it. And then based on the conversations we had in the fall of 2019, we came away from that day in September 2019 with 2 charges. One was to develop a set of principles for healthcare providers, staff, institutions, and associations to adopt and effectively implement to interrupt medical and healthcare and care providers and public health workers' participation, facilitation, and condoning of criminalization of people seeking care. The other charge we had was to organize people who were working to divest from policing and punishment and fight criminalization, to do some work and some education and create some materials to make sure that in doing that work, we weren't just turning people over to criminalization in the form of coerced treatment and criminalization in the context of medical care. Over the past 3 years, we've moved both of those conversations forward. We've spent 3 years workshopping a set of principles that you'll see and hear about in just a second, and that you saw looping at the beginning of the presentation. And we also had conversations, particularly in the context of the 2020 uprisings, about what folks who are calling to divest from policing and punishment, making sure that we don't call for things like quote unquote treatment, not punishment, when the treatment is the punishment, the treatment is the trauma, the treatment is another form of criminalization, coercion, and control. So we had those conversations through 2020, 2021, and then we were joined by the universe, gave us a tremendous gift, an incredible opportunity to work with Maria Thomas, who is our Beyond Do No Harm Fellow, who has spent the last year deeply workshopping the principles that the network members had been generating together with different populations and with folks across the network, to the point where we have a final set of principles to share with you tonight. Now, our plan had been to continue to workshop these. So I just want to, before jumping in, say that these are in progress. These are a work in progress. We had intended to spend more time refining them, workshopping them with different populations of folks and movements of people who are criminalized in the access to health, in the context of access to healthcare. But as we all know, criminalization in that context has accelerated rapidly over the last year. And we saw in the wake of Dobbs and in the wake of legislation around the country attacking trans healthcare that people were posting and saying someone needs to organize healthcare providers, someone needs to support healthcare providers in standing against this criminalization, someone needs to, and we were like, we've been doing that. We have a container that we're creating. And so we sort of sped up our process to get it out there for you, even if it's imperfect and unfinished, to invite you into that project with us. So that's what we'll be doing tonight. We'll hear from Kara, who's going to offer a grounding for us again in the history of the criminalization that we're fighting and the institutions and structures that it serves. And then we will be hearing from an incredible panel of network members, and all of our network members are brilliant and contributed to this tremendous body of work, but we'll hear from just a few tonight about where they're seeing criminalization happen in the context of healthcare provision and why it's particularly critical for healthcare providers, staff, and public health workers and researchers to commit to these principles in this moment, and to invite people to join them in doing so, and to talk about how providers can do that and build broader support for it. So that's our agenda for tonight. The principles were available at the beginning. Rather than take any more time running through them, I'm just going to invite our team to drop in the chat the brand new website with all of the principles on it that Maria Thomas created for you all to make it really easy for you to access the information. So you can look at the principles there as we go along. But without further ado, I want to turn it over to Kara Page, who is the founder of Changing Frequencies, the Healing Histories Project, along with several other collaborators who I know she will shout out and credit, and also of so many other amazing spaces, conversations, and places of dreaming liberation. So with that, I'll turn it over to you, Kara, to take us through, to ground us in this conversation as you did at the beginning.
Thank you so much, Andrea. This is beautiful. I'm not going to turn on my camera because I have a really bad signal here on Lenape-Munsey land, otherwise known as Brooklyn. Something's going on with my Wi-Fi. So I'm just going to share slides and go directly into that. It's deeply exciting and an honor to be here with all of you this evening. Again, Andrea, you beautifully introduced me. I'm representing many places and spaces and future visioning, but in particular, the Healing Histories Project, a network of abolitionist healers, health practitioners, community organizers, researchers, historians, and cultural workers, we are building solidarity to interrupt the medical industrial complex and harmful systems of care. And we are generating change through research action and building collaborative strategies and stories with Black, Indigenous, people of color-led communities, institutions, and movements organizing for dignified collective care. We are very much in partnership with many organizations, collaborations like Interrupting Criminalization, and excited for this report that I was at the onset a part of these conversations. And the co-founders of Healing Histories Project couldn't be here tonight, but Anjali Taneja and Susan Raffo and many others that we are working with are deeply honored to be included in the report. Let me share the screen just to move into the slide deck this evening. Hold on 1 second. Sorry, hold on 1 second. Technical difficulties, but here we are. Okay. Most of the slides also are in Spanish as well, bilingual. So hopefully that will also support multilingual experience. Just a few are the slides are back to back. So on this one, the next slide is in Spanish. I just want to say that Healing Histories Project's work is deeply rooted in healing justice, a political framework and strategy that I've been working with the Kindred Southern Healing Justice Collective for over 15 years to build, that seeks to transform generational trauma from systemic oppression, colonization, and slavery, including the exploitation, experimentation, and harmful abuses of the medical and prison industrial complex by regenerating our cultural, spiritual, physical, emotional, psychic, and environmental practices and traditions as integral to our political liberation. That is what called us 15 years ago in the Southeast, and building since then with the Global South, with healers and practitioners that are transforming ways to not repeat the harms and abuses of the medical industrial complex. We, the Healing Histories Project, just to name, we've been working for a while, as many people have heard. We've been working on the medical industrial complex timeline, a timeline that seeks to really uplift the intersections of oppression, structural violence, institutional violence, and resistance of the medical industrial complex. It is based on relationships and a long-term partnership with many organizers, doctors, nurses, social workers, and abolitionist healers. We've been working on this in cycles for over a decade. And to be quite frank, we actually lost funding during the beginning of COVID years, because we were being critiqued as being anti-science and pro-Trump, because we were critiquing public health. And so we lost a funder that was helping us move this to a digital timeline. So just in terms of who's seen as a threat, that even to critique public health, even to understand its analysis and alignment with enslavement, prisons, and exploitation of our people, also means being taken, having the resources taken away from us as well. So the prolonged process has landed us on finally being able to lift up the timeline. It will be digitized, open source by spring 2023. And in the meantime, at our healinghistoriesproject.com website, we've had a COVID timeline to begin to track what we feel is on the precipice of a new moment of abolition, by building public critique, analysis, and transformation, as Andrea so beautifully named, as all of the partners and members of this network are speaking to. is how COVID is changing, has added to both the increased criminalization of frontline care workers and also the increased resistance. So I'll briefly discuss the medical industrial complex and how we have been describing it inside of Healing Histories Project and some of the projects I'm also working with, including Changing Frequencies, a cultural memory project that seeks to build story and cultural work that names sites of harm and abuse by eugenic and medical violence in the US. But essentially, just to land some of the structural institutional violence that is deeply embedded in the medical industrial complexes, we are always talking about the impact of individual, collective, and generational trauma that is deeply impacted by the conditions of the medical system. And I'll talk about the working definition of the medical industrial complex in a moment. But just essentially that we are always looking at the Healing Histories Project, I believe in interrupting criminalization. Many organizations and collaboratives that I'm seeing really expand both in the US and in the global South to critique the system of care that has been used to perpetuate violence and oppression on communities, so many marginalized communities, or basically our people, right? Black, Indigenous people of color, sex workers, drug and substance users, queer and trans, gender nonconforming, disabled communities, incarcerated communities, that we are at the center of being directly impacted by the trauma from ways testing, experimentation, and being associated to disease and threat and danger, literally based on our biological existence. And I always like to just show that inside of the medical industrial complex, we are always looking at white supremacy, heterosexual supremacy. We're always looking at adult supremacy, patriarchy, Christian supremacy, and understanding that the systems of colonization and slavery, eugenics and population control, systemic oppression and capitalism, racial capitalism, is deeply fueling this medical industry, and in some ways a system of care that is not liberatory, that is not based on the survival, dignified quality care and well-being for our communities, but is simply based on those who are seen as incurable, as undesirable, as dependent on the state, that being many of our people, and those who are seen as preserving health, preserving beauty, desire, and wellness. And I'm going to talk a little bit about this briefly, is this idea that the medical industry, at least, I'm going to just speak to the US, but we know it's throughout the world, and the global pandemic showed us that, is that this system relies on this idea and purity of a wealthy, white, cis, heterosexual, able-bodied, masculine, and Christian identity or ideal of whose body is healthy and whose body is diseased. And as Patty Burns says, from Sins Invalid, a disability justice activist and artist, whose bodies are seen as pure and whose bodies who are perceived as sinful, is deeply based on this very idealistic, systemic understanding of medicine and care being directly associated to preserve one type of body, and that, as I'm naming here. And then this idea that who is expendable and who is deserving of access to quality and dignified spiritual, emotional, physical, psychic, environmental, and mental care, and those who cannot, right? So really setting the dynamic, the binary of who can access not even dignified quality care, but who can access care that is deeply spiritual, deeply related to the cultural understandings of how our communities survive genocide, slavery, and oppression, by being able to access traditions of care, practices, foods, and medicines without those being criminalized or displaced, or without practitioners being persecuted for believing in these practices that is outside of a Western-based model of care. And then we're constantly looking at whose bodies are perceived as criminal, disease, and pathologies, and how the medical system is deeply embedded in this idea still based on eugenics, old ideas, white, wealthy, straight, cis, male, masculine, Christian, ableist ideas of whose bodies are fit and whose bodies are unfit to survive. And still looking at that Black, Indigenous, people of color bodies are only meant to exist solely for the purpose of labor and reproduction for the wealthy elite. And if we're not looking at the system of care through that lens of what we are pushing up against, it's a missed opportunity to be able to really transform the root causes of this institution. And then just finally, as an extension of state control and violence, this is not quite the last one, a little bit more, is using this institution as a platform for surveillance, for policing, and erasure of our bodies that are seen as expendable, incurable, unfit, and abnormal, I say in quotes, but also relying on a doctrine of fear, right? That sets the medical industry up, and medical industry includes clinics inside of prisons and detention centers, right? Includes social worker systems that have preserved or created this concept of family, who is these ideas that are inside of curative models of what is a good family, what is a bad family, what is unhealthy, practices as parents. You know, there's so many nuances into how the medical and public health system in this country permeate this constant doctrine of fear, that you don't want to be associated to the diseased, right? Or to those who are outside of anything outside of Western-based medicine and care. And so what we're looking at inside of the medical industrial complex is to push up against an enforcement and a militarization of a global responsive care that is deeply embedded in national security and ideas of who is meant to be protected and who is meant to be feared. And that includes practitioners who are outside of Western-based models of care or pushing up against systems of violence and abuse inside of the system, which I will toss it back to the panel that I know we're going to go deeper into these strategies that put care workers at the center and at the risk and courage and bravery to change these harms and abuses of state and private systems. Thank you.
Thank you so much again, Kara, for grounding us in all the ways the systems and structures that shape what we see in terms of criminalization in many, many places of care, or that denies people even access to those spaces of care. And I guess I will kick the panel off, and I'm going to ask everyone coming after you to the same question, but just as you're leaving the stage, I'm going to kind of grab you and pull you back and ask you, given the history that you just laid out for us, why is it particularly critical for healthcare providers, staff, researchers, and public health officials to commit to these principles of non-participation, facilitation, or condoning criminalization at this particular moment in history as a memory worker?
I mean, why at this particular moment? I mean, I tried to name it because COVID opened up a portal, right? And I think many of us have been doing this work for a very long time, but it is such a vibrant moment for us to interrupt. I am watching people make a direct correlation, right, to the uprisings against police brutality in relationship to how people with mental illness, mental disabilities are dying at the hands of police, and understanding, oh, this is the same system that the prisons, the mental health systems, the social work, the medical industrial complex as an industry of care is actually profiting off the policing and killing of Black and brown, queer, and trans disabled bodies, and of incarcerated and detained bodies. So all of this came to this culmination. And as you know, as we all know, presenting on the panel, it became another moment. This is what I mean. We are breaking through a portal, and people are ready to have this conversation at such critical mass, where before many more people were operating in isolation. And on the other side of this, yes, I'm a culture worker, also as a practitioner. I have worked as a healer for 2 decades. I have watched the persecution of healing practitioners, from birth practices to abortion practices to harm reduction practices, be criminalized for their work, and in certain parts of this world be executed for their work. So it is a heightened moment, as I think it's been for a long time, that people didn't see it, that healers, care workers, birth workers, their lives are at risk. And if we are not building a political infrastructure, spiritual, cultural strategy that responds to that, we are already decades behind. But let's be ready for the next 2 decades ahead. This is future visioning that I am deeply committed to, and I see a lot more people making the correlations, Andrea, as you know, that is why this is the moment, is a critical moment.
Thank you for letting me grab you and hold you for that, because I knew you would deliver exactly that charge. So thank you so much. I'm now going to invite our panelists to join us and ask each of them to briefly introduce themselves and describe yourself for folks who are not able to see in this moment, and share first what brings you to the conversation and why you think it's particularly critical for healthcare providers, staff, researchers, and public health workers to commit to these principles at this particular moment. So I'm going to ask you all to do 5 minutes on that. I'm going to start with Dr. Jamila Perritt, and then I'm going to go to you, Gabriel, next.
Thank you so much. Thank you for that grounding. It was just so critical in terms of framing how we're going to move forward. As you mentioned, my name is Dr. Jamila Perritt. I use she, her pronouns. I am the president and CEO of Physicians for Reproductive Health, and a clinic-based abortion provider and OBGYN in the city I grew up in Washington, D.C. At PRH, we're a network of doctors around the country working to advocate for comprehensive reproductive health care for the communities that we serve. And we do this in a number of ways, including communications and public policy work, understanding that all of these things shape and impact the care that we can provide. I am calling from Washington, D.C., and that's Piscataway and Anacostan land. I'm wearing bright red lipstick. I'm a brown-skinned Black woman. I have curly hair and big hoop earrings that I always wear, despite the recommendation that we don't, and the suggestion that it may be unprofessional. I still rock my hoops. And I have, I'm sitting in my home office with a bookcase behind me and a painting on the wall. So to your question about why is it critical at this moment for us to commit to these principles, I guess I would respond in kind with another question: why not? It has taken so long for us to even acknowledge in the medical space that this is happening, and we are far from universal acknowledgement of that still. And so as someone who has been gifted by the universe with a platform to talk about these issues, I feel like it is my obligation and certainly an opportunity to talk about those connections. I always wanted to be a doctor. There's not anything else that I have a memory of ever wanting to be. And when I entered medical school and my medical training, I did so with a deep commitment to health and wellness and healing in the community that made me who I am, which is why I continue to provide care in the community that has supported me my entire life today. But I also knew that there were pieces of the work that I would not be able to impact by simply providing clinical care in organized medical spaces. And understanding the connection between the medical industrial complex and the prison industrial complex is something that actually came much later in my career, even though I had those values inherently grounded in me as I entered into medical education. Seeing those connections for me honestly did not occur until that meeting at Sister Song in 2019. And seeing it really laid out so explicitly, there was no way, you can't unsee, right? You can't unring a bell. Once it's there, it's there. And the question becomes, and it became for me, now what are you going to do about it? Now that you know, what will you do? The challenging part about medicine in the medical industrial complex is that we are taught to believe that we're small and ineffectual. And that's rooted in the ties of medicine, the ties that medicine has to white supremacy values and principles, right? It's designed to make you feel isolated, alone, powerless, especially people who look like me. And so an opportunity to disrupt those things, disrupt those ideas, those contexts is going to be really critical. And we are powerful beyond measure. That is why we are experiencing these attacks. That is why we are criminalized at such a large scale, because of the power that we hold as individuals, and certainly the collective power in our communities and the work that we do as healers. I've always believed that health and wellness is a liberatory path. It is the reason why I came into medicine, but we cannot be well when we are being hunted. And that is exactly what's happening, whether we're inside or outside of medical spaces. We have convinced ourselves in our hospitals and our clinics and our offices that medicine is the only institution that is uniquely absolved from the legacy of white supremacy, of genocide, of enslavement. And we all know that that is simply not true. And so this is an opportunity, by naming these principles, really actions around what can we do as healthcare providers, those of us who often hold the most power in these systems. How do we take advantage and leverage that power for the greater good, for health and wellness and healing in our own communities? Thank you for the opportunity to be here. And I hope I answered the question.
You absolutely did, as you always do, Dr. Perritt, on point, and speaking powerfully to a lot of the healthcare providers who are here asking questions in the chat, and for folks who are wondering how to do some of what Dr. Perritt is describing. That's what we are here to offer you tonight, some tools to do it, and then also invite you into helping us create more tools to do it. So this is a collective endeavor. I'm going to pass it now to Gabriel Arkles, who's someone who has taught me, as Kara Page has over 2 decades now, what criminalization through access to healthcare looks like, particularly for trans and gender nonconforming people, and who joins us tonight to offer their brief description of what brings them to this work, and also why it's particularly critical in this moment of just rampant attacks on trans healthcare and trans people, for healthcare providers, staff, and others to commit to these principles at this moment.
Thank you. It's always such a pleasure to speak with this group of people. My name is Gabriel Arkles. I use he, him pronouns, and I'm a bald, white, trans man with facial hair and glasses, seated in front of a bookcase. I'm senior counsel at the Transgender Legal Defense and Education Fund, and in my copious spare time, I also volunteer with HERD, which is a cross-disability abolitionist organization, Masjid, spelled M-A-S-G-D, which is a queer Muslim organization, and the Alyssa Rodriguez Center for Gender Justice, which builds with folks working for gender justice across prison walls. At TILDF, I mostly work on cases that are about challenging some of the violence that trans people experience in jails, advancing and protecting trans access to healthcare, and helping trans people, including those with criminal convictions, get access to ID with the right name and gender marker, all issues that are deeply relevant to what we're talking about today. when thinking about this moment and why this issue is important, I can tend to get a little bit overwhelmed because there's so much happening in this moment. Removing criminalization from healthcare settings and from all settings in the world is a crucial issue at any moment, but especially so now, I think. When I first started doing this work, trans legal advocacy, it was in the early 2000s. And it was soon after New York had changed its rules about Medicaid to take away coverage for gender affirming healthcare for trans people, like Florida just did this year. And it was a time of crisis for our communities. A lot of people were without care. A lot of people were participating in criminalized economies to try to pay for their care. And a lot of people were helping each other to get access to care anyway, including access to self-managed or community-managed care. And of course, we would learn about that care being criminalized from time to time. One example that I want to share is a Black trans woman getting sent to prison because she provided a silicone injection both to herself and to another trans woman, and the other trans woman died. Silicone injections are dangerous, but the response of sending somebody to prison, to me, seems like the most cruel and counterproductive of all possible interventions if what you care about is the safety or lives of Black trans women or other trans people who don't have the money or the access to be able to get care from a surgeon. And medical providers, along with plenty of lawyers, always play a role in these cases. There was one case where there were 3 separate doctors who agreed to serve as experts for the prosecution. These weren't treating providers who were dealing with a subpoena and worried about consequences. These were people who chose to offer their services to the prosecutors to send this woman to prison. And once she was sent to prison, this is Tracy Lee Garner I'm thinking of right now. She died 3.5 years later in that Mississippi prison. And there were even more providers who were speaking to the media about the dangers of these injections. But if you want to keep people from dying, then there are so many other things to do in terms of trying to advocate for people to actually be able to access this care in safe ways, in terms of talking to community members. So if they decide to get a silicone injection, they know what they're getting into. But speaking to the media in ways that end up supporting the prosecution, I think is just another way that sort of feeds into criminalization. And then of course, however people are criminalized, there's also connections with medical providers on the inside. And one example which has stayed true from when I started this work around 2 decades ago until now is medical providers getting enlisted in conducting genital check searches of trans people. And I can think of one time when there was a young Latina trans woman who was brought to jail. They thought she might be trans. They then took her to a hospital. And they asked a doctor to examine her genitals and describe them. She was crying and begging them not to touch her. The doctor said no. The corrections folks went to a second doctor. She also said no. And they went to a third doctor and he said yes, then reached in her pants and felt her genitals and described them to the corrections officers while she wept. And I feel a lot of rage when I tell that story, but what I actually want to focus on is the first 2 doctors there who said no. and honoring the ability of medical providers and the courage of medical providers in saying no in those situations and in so many others. And in this particular moment, we're seeing access to trans healthcare taken away in so many different states and in so many different ways. And we're also seeing an intensification and an escalation of the criminalization of trans existence in public, and particularly Black and Brown trans existence in public. And we're also seeing, and this I think is new, criminalization of our providers, of our family members, for trans young people, virtually any supportive adult in their lives. And I think this is a moment when all of us who care about these issues, who care about people just being able to live and survive, need to be coming together and supporting each other and finding every way that we can help each other in providing the care that people need and saying no to the various ways these systems try to enlist us and implicate us in carrying out criminalization. And for those of you who don't currently provide healthcare, gender affirming healthcare to trans young people, if you know any, I would suggest sending them some support in this moment. It's not an easy time, I think, for any of us. Thank you.
Thank you, Gabriel, for this powerful outlining of exactly the multiple ways that criminalization happens, and for a really powerful call to arms to be the provider who says no. And that is essentially what we are calling on the providers and staff people and researchers on this call to be, and to invite others into being, and to support each other into being. So thank you so much. I'm gonna turn now to Kebé, who from the National Advocates for Pregnant Women, who works on criminalization of self-managed care that Gabriel just referred to in a different context in terms of pregnancy, self-managed abortion care, but also the criminalization of pregnant people and coercion and control of pregnant people in so many other contexts beyond abortion care. So turning it over to you, Kebé, to describe yourself, tell us how you come to this work and why it's really critical at this moment for providers to be involved.
Thank you, Andrea. I'm definitely still sitting with the words of everyone who's already spoken, and I think it goes to show how long we've known each other, because I'm not at NAPW, I'm with If When How, lawyering for reproductive justice. But thank you for having me tonight. Like Andrea said, my name is Kebé. I use she, her pronouns. I am coming to you from the traditional homeland of Muskogee Creek and Cherokee peoples who've been forcibly removed from their land. I am a brown-skinned Black woman with long brown braids, a burgundy shirt, and a white sweater, and clear glasses. I'm sitting in my office with a blurry background. I'm also, like I mentioned, I'm coming to you as senior legal support advocate at an organization called If When How. I am a movement builder with deep ties to reproductive justice who is committed to direct support and to building power toward reproductive freedom. That's where I stay in this movement constellation. And If When How is a legal advocacy organization. We work on law, policy, direct support, litigation, and building out our movement. We work toward reproductive justice by attempting to transform the legal system while collaborating across movements and acknowledging the intersection of identities and letting that shape our work. What brings me to this conversation tonight is that my work for the past 5 years has been building access to legal information around self-managed abortion, because people always have and always will access and build networks of care outside of the formal healthcare system, and that includes the full spectrum of reproductive experience, and that includes abortion. I came into this work about 5 years ago from working on pregnancy criminalization more broadly, but at a moment when we were staring down the end of Roe and diminished access to clinical abortion care, the political climate that we're in now, and existing criminalization to pregnancy loss. And so our work is to ensure that no one is criminalized for their self-managed abortion, regardless of how. One of our interventions there is, again, to provide direct legal support and access to legal information. And so I was most directly involved in building a resource called the Repro Legal Helpline. It's a resource for people who've self-managed or considering self-managing their abortion care and have questions about laws that are very confusing, and even more so in this moment. I will also mention that even though I don't work directly on it, we have a Repro Legal Defense Fund to support bail and legal defense for folks who are experiencing abortion criminalization. And I'm excited that these principles are being released into the world, and like looking forward to how they'll move in the world, and just to get to talk to providers and imagine what their roles can be in what their interventions can be in criminalization. In response to your question, Andrea, about why it's particularly critical in this moment, I am going to focus on the moment for reproductive justice in the US, and even more specifically on abortion criminalization within that. We're at a place where the Dobbs decision came down in June. That's marking the end of an era of dwindling access to clinical abortion care under supposed constitutional protection that we both relied on, and also was never enough. And we've moved into this moment of uncertainty. New bans are being passed, old bans are going into effect. There's a patchwork of different kinds of restrictions forming. And so we're inside of this shifting legal landscape that's creating, again, confusion and uncertainty for a lot of folks. And that patchwork of restrictions and the changing legal landscape is also creating uncertainty for providers in moments when they are called on to exercise their own discretion. And that uncertainty is intersecting with abortion stigma that can color people's assumptions about a situation, and especially when to report or when to call law enforcement. So that said, I do want to lift up that, generally speaking, most of the new or newly in effect abortion bans post-Dobbs make it a crime to provide or perform an abortion, but they don't make it a crime for someone to have an abortion. And that most of those laws make that explicit in the statute. So both before and after the Dobbs decision, the law overwhelmingly doesn't make it a crime to have an abortion. In this particular moment, the public is unclear about whether it's a crime to have an abortion, where the law is actually very clear. And so we have to remember that criminalization is both to make something a crime and also to treat someone as a criminal. And it's the latter definition that's important here, that criminalization is hitting hardest folks who are already treated as suspect inside of the medical industrial complex. And considering the role of providers, they are positioned to give care and medical treatment and support to pregnant people who are having abortions and pregnant people who are having a miscarriage. And I will also lift up that back in August, my colleagues Laura Huss, Farah Diaz-Teo, and Golene Samari published a brief of preliminary findings from their research on self-managed abortion criminalization. And their preliminary research findings uncovered 61 cases of self-managed abortion criminalization from looking at the period of 2000 to 2022. So keep in mind that's likely a huge undercount because not all public records requests return data. Not all cases are reported on in the media, and it's fundamentally challenging because it's using the legal system itself to try and identify unlawful cases. But of those cases, adults who were investigated or arrested or prosecuted for a suspected self-managed abortion were most often brought to the attention of police or law enforcement by care providers who are mandatory reporters. And once law enforcement was involved, the vast majority of adult cases led to an arrest. Again, we're looking at 2000 to 2022, and those arrests and investigations and prosecutions are all while Roe is still ostensibly the law of the land and abortion is constitutionally protected. The data also tell us that Black folks, Indigenous folks, and people of color are overrepresented in these cases, and that a homicide consideration was twice as frequent for cases involving people of color. So I'm pointing to research, but our movements have known this and held these stories and experiences of criminalization of reproductive experience for decades. And in this moment of a cascade of abortion bans and restrictions, this moment of so much stigma and uncertainty and more people self-managing their care, it's especially critical for providers to understand their positionality and their opportunity to intervene in and to disrupt the criminalization of pregnant people and people who are coming to them for abortion aftercare.
Thank you so much, Kebé. I would invite folks to check out a website called Mandatory Reporting is Not Neutral, to also investigate the question of what you are mandated to report and what you are not, along the lines of what Kebé just outlined, and then also to note that one of our principles is to end mandated reporting. And one of the groups that really helped us understand the importance of that in the context of criminalization of both pregnant people and parents is Movement for Family Power. So I wanted to invite Erin Miles-Cloud to introduce and describe yourself, share what brings you to this conversation and why it's particularly critical for healthcare providers to commit to these principles at this particular moment.
Thank you so much, Andrea, and I'm really excited to be here tonight. My name is Erin Miles-Cloud. I use she, her pronouns. I am a light-skinned Black woman with very gray hair at the front and really sadly dyed hair in the back. I think about 3 inches of roots now. I have bright red lipstick, a gold chain, so pop my gold chain with Dr. Perritt's gold earrings. I have some glasses on, a green sweater, and I have a white background behind me. I normally am calling in from the Bronx, Lenape land, but today I'm calling in from Austin, which is Tonkawa land. I'm really excited to be here today. I am the co-director of Movement for Family Power, and we do work to end the policing and punishment of families through the family policing system, also known to many people as the child welfare system, or what they might have understood to be the foster care system, despite that system not actually providing care. We really believe that Black and brown mamas, including poor mamas, love and care for their children, despite what they say. We believe that parents and people who use substances are valuable in our world. We believe that we are in community with drug users, that many of us use drugs, and that does not take away who we are, how we love, and the dignity that we provide in our lives and to our families. We believe that mamas who use substances are mamas too. We believe that there is treatment and healthcare within our families and within our communities that can be uplifted and can be in community with what is provided in our medical systems. Now, the question is, why now? Well, from our organization, we reject that what is called child protective services is in fact protective. We reject that it is a system of support. So why now is because we need deeply for our families and for our children to survive. And so there are 3 reasons I come to you today with urgency: personal, political, and systemic. On the personal level, I just quite simply want a world where my children and all families and mothers and parents feel freedom in their body, an unabashed freedom, a security that you can receive care. I want a world where I know for sure that I can access support, and so can my family and everyone around me. On the political, we've obscured the history and relationship between the foster system, or rather the family policing system, and the medical industrial system too long. And the longer we obscure this history, the harder it will be to repair and actually build the supports we need for our families. This is particularly true for the political relationship between pediatrics and pediatricians and the foster system. And it's especially true in our ways that we understand the war on drugs and how the war on drugs is steeped in all the medical policies, laws, and procedures of doctors. From the political moment is now, it's been now, to end the war on drugs in our medical system and everywhere. It's also now to end the womb to foster system pipeline. From the systemic level, why now? Because surveillance is not support. Medical providers are mandated reporters, and they're one of the largest professions that choose to report. And I want to be clear, choose to report instead of care. And if we can instead turn away from surveillance and turn into support, then we will be turning away from carceral solutions and building back into the true heart work, the care work that we are obligated to do. And that gives us the opportunity not only just to survive, but to thrive. So your question, Andrea, is why now? Is because honestly, we deserve to thrive, and I'm ready for it.
We're all ready for that world. We're so excited to keep talking about how we build it. Thank you, Erin, for walking us through that. We're going to take a break for our Access team. And during the break, we'll again show the slides with the principles, and also I believe Maria will drop in the chat the website that she beautifully created to showcase the principles and the support materials, and you can have a look at those during the break or just take care of yourself. We'll be back at 48 minutes after the hour, wherever you are, and we'll return with one more panelist, and then we'll come back around to talk about how you can get involved. So stay here, stay tuned, and come back at 48 minutes after the hour. Welcome back, everyone. Thank you, DJ Erin, for taking us through the break. I'm going to ask our last panelist, Christine Mitchell, to introduce herself, describe herself, and share what brings her to this conversation and why it's particularly critical for public health workers and researchers to commit to these principles at this particular moment. And then we'll come back through all the panelists to give you very specific ways they imagine that you can implement and build support around them, and then introduce you to some tools that you all can take away to do the work. So Christine, welcome, and let us know who you are and why it's important for folks to act now.
Thanks, Andrea. Hi, I'm Christine Mitchell. I use she, her, hers pronouns. I am a white woman. I'm wearing a dark green sweater, have short dark hair, dangly earrings, and I'm sitting against a wall that has some framed photos behind me. So I am a member of the End Police Violence Collective, which are public health researchers, workers, advocates, organizers who co-authored 2 policy statements for the American Public Health Association. One that was passed in 2018, which was about police violence as a public health issue, which was sort of covertly abolitionist. We didn't use the word abolition in it, but it very much was. And then sort of by the time everyone agreed to it and thought, yeah, this is totally public health, we were like, yeah, well, that's abolition. And then we passed another one in 2021 that was about carceral systems and the harms of carceral systems that did explicitly use an abolitionist framing. And so now that is also official policy of the American Public Health Association. And I got involved with the Beyond Do No Harm network, sort of amidst the beginnings of COVID and the uprisings for Black liberation in 2020. We wrote what we call the Pledge of Non-Collaboration, which was a pledge for public health workers to not collaborate with policing. So that included things like not doing research at police's behest or in a way that supports their work, not promoting false solutions like body cameras, community policing, more training, and not using policing to enforce public health guidelines. And so the point was to make clear that policing and public health are antithetical to one another, and therefore they should not and cannot collaborate. And an interesting thing that happened with the pledge is we gave people an option to sign anonymously, and if they signed anonymously, to let us know why. And so several people signed anonymously and gave the reason that they believe in the pledge, they believe in the principles, but they worked for a Department of Public Health, and their department were close partners with the police, so they didn't want to sign publicly. So I'm here for that reason. Public health as a field has a long history and a very real contemporary reality of systemic racism, eugenics, collaboration with policing, and contribution to criminalization. So I'm sort of coming at this from a public health angle, not from a healthcare angle, sort of seeing these as two very connected but separate pathways. And yeah, so we have the abolition statements as part of our professional organization. We talk about health equity all the time, but what are we actually doing to put these principles into ending criminalization into our practice? And how are we participating in criminalization, and how do we interrupt that? And so to get to the second part of the question, which is why it's important right now for folks in public health to commit to the principles. I think one thing that's standing out to me is, yeah, just to echo what Kara said earlier, that this moment of COVID sort of opened a portal. I think it did that for a lot in public health. So eyes are on public health right now in a way that it hasn't been before. I remember when I started studying public health, my mom was like, what is that? And I really couldn't answer. And now suddenly people understand what the field is and does in a new way. And so that provides the conditions, not to mention, a lot of funding is being funneled into public health right now for folks who are in public health to push for policies that allow people to access the care they need or want without fear of criminalization. And then just to echo what everyone's been saying, which is that this is a major political moment that the right wing has been organizing towards for decades, and it is very public and very coming to fruition around the criminalization of abortion, the criminalization of trans folks, this challenging of quote unquote critical race theory, which, let's be real, it's not actually critical race theory, it's just history. And then also the state and public health leaving disabled and immunocompromised people and our elders to die as COVID is continuing to spread, and we no longer have protections in place in many places. So it's sort of the context that we're in. And it's also just an important moment for coalition building, which I think the Beyond Do No Harm Network has done really beautifully, making that point that all of our movements are connected. that disability justice is trans justice, is reproductive justice, is racial justice, is migrant justice, and so on. And I feel like often in our organizing work, we are so siloed. And in the healthcare world and public health world, I feel like we're also very siloed. And so this moment sort of gives us an opportunity to build together, and yeah, within our fields of healthcare and public health to take on these principles and refuse to participate in the criminalization that we're seeing take off right now.
So I'm going to invite you to answer the next question first, as you answered the last one last, is how specifically can you imagine public health officials implementing and building support around these principles? And if there's any particular calls to action or solidarity that you want to share with public health officials, researchers, workers, the floor is yours.
Thanks. Yeah, I think the thing that I think about in regards to that question is like, how can we make these principles irresistible? How can we make these principles mainstream so that it's actually the criminalization that becomes the aberration? And I think that that has to be sort of a movement from the ground up, this groundswell of folks signing on to these principles and then bringing in other people in their health departments or other people in their department at a hospital, or you know, students bringing this to sort of start right at the very beginning of the training process to commit to these principles. So I think there is a lot of space for us to sort of organize at that very grassroots, having tons of one-to-one type level. I think it's a commitment that people need to make every day. And I think hopefully we can build communities of support that can, support each other to build alternatives in hospitals and health departments, supporting each other when challenges come up. You know, when people are refusing to criminalize and they get called, you know, called in for it, just making sure that we have systems of support set up for people to be able to handle that and face that and not feel alone in it. I think for public health specifically, in an ideal world, it should be very easy for public health professionals to take these principles on. It should be very clear that public health should be about investing in what we call the social determinants of health, all the things that people need to live healthy lives: housing and education and employment and transportation and so on. And dismantling the systems that harm health, right, which are systems of criminalization. It's what we talk about all of the time, but it's of course not always what we do, or maybe not even often what we do. And so I think that really this like helping people align values to practice feels like a really important part of this. And I think thinking back to the pledge of non-collaboration and people feeling like, I agree with all of this, but I can't do it, right? And so how do we bring that together? One call, can I say one call?
Yes, so one call action. Go, sorry, we're done.
That's okay. We did not plan this webinar around the American Public Health Association conference, which we did do a couple of years ago, but it turns out that that conference is this weekend. And it's in Boston. And on Sunday, the 6th, there will be a rally for reproductive justice. If you're in Boston, it's at the Seaport Convention Center entrance. I can post this I'll put this in the chat after. The American Public Health Association encouraged people not to go to this rally. They said, instead of going, call your senators or share the things that we have on our website. So it would be really great to have a strong showing there to make very clear that reproductive justice is a public health issue and we need to be front and center in it and not silent. Thanks.
Thank you so much. I'm going to come next back to Erin Miles Cloud about sort of following up on some of the questions we're seeing about mandated reporting specifically. How are some ways that you can imagine that providers can implement and build support around that principle and others that are relevant to your work? And to note that we are going to try and create some of the resources that Christine just talked about to support people in doing that as well.
Thank you so much. One, I'm so sorry about my technical inabilities. I think I did respond to Dean Bridges with some resources. So when it comes to mandated reporting, it's actually not building out support. It's not building out protection either. So a lot of times people will say, you know, I am concerned about not reporting in cases of serious harm. So I did drop some resources in the question and answer. The long and short of it is that it's not actually decreased any serious harm, fatality, sexual harm to young people or parents, despite us putting millions of dollars into this particular system. It's definitely not prevented that particular harm. In the case of intimate partner violence, it's survivors themselves that are asking for us to not have mandated reporting. And I think to live in the double consciousness that we want mandated reporting, despite the fact that survivors are saying this has not kept me safe, is really illogical. And we need to be listening to survivors of intimate partner violence who have faced child removal, who have faced criminalization, who have faced hostile medical systems for experienced violence. So they're experiencing violence, they're going to places of care, and then experiencing another system of violence, and they're asking for it to stop. I would really ask people, like, if we want to dig into this particular topic on November 10th, I'm super excited to be in conversation with Dean Spade, Jasmine Wally from JMAC for Families, and Shannon Perez Darby at Mandatory Not Reporting. And we're going to just spend literally 2 hours on mandatory reporting. And I really think that's a time for us to spend and dive into why we are so connected to this particular system that has actually not served us or prevented harm, and what are possibilities. I would also just encourage people to consider the political moment we're in right now. Right now, there is a concerted attack on Indigenous tribes and Indigenous sovereignty that's happening through the child welfare system. There's a Supreme Court oral arguments that are going to be held November 9th. The case is Brackeen versus Holland, where the same companies and the same law firms that are protecting big oil, that want land, that want access to pipelines, the same attorney general and court system that overturned Roe are actually asking to undo ICWA, the Indian Child Welfare Act, which was a law that was put into place to protect against the genocide of Indigenous people that happened for the larger part of the 20th century, such that 1/3 of Native children were removed from their families. And so when we're talking about reporting, think of the precarious nature. You're sending people to a system that, one, is rooted in genocide and is being attacked right now. And so the legal protections to keep them in their tribes, to keep sovereignty available, are simply not there. So I would encourage people to sign the petition, to be aware the act's going to drop it in the link, and to really show up in solidarity. Finally, when we're talking about mandated reporting, we have to understand that the family regulation system is the largest system of social control for pregnant and parenting people who use drugs. It's the #1 legal form that we have to actually regulate the bodies of pregnant people right now. And that is especially true for people who use drugs. And we know that with the overturn of Roe, that we're seeing increased criminalization in the criminal legal system. But what we're not talking about as often is that the consistent and increased criminalization we're seeing in the family regulation system. And that really goes from drug testing, drug screening, to reporting, right? And what I really encourage people to do is check out the Informed Consent campaign that is happening in New York City, in Maryland, in California. This is an opportunity for medical providers, people like you, anyone on this call. I really beg you to go into this letter of support, go click on it where it says, add your name here, please click on that and add your name there. They need to hear from you. They need to hear from you that actually reporting to the family policing system has not actually been supportive, that you don't want to do it anymore, that you want to provide care, that you know right now that when you report to the family policing system, you're increasing chaotic use, you're increasing the risk of suicide, you're increasing the risk of violence, and you're increasing the risk of someone being brought into a system of non-care, of non-trust, and a system of surveillance, and a system that has shown to be a prerequisite to the system of incarceration. As Joyce McMillan says, and I encourage y'all to look at the work she's doing, she's convening people, mandated reporters right now that want to do something different, that the foster system is a prerequisite to the mass incarceration in the criminal legal system. So I gave y'all lots of actions, lots of resources. And while I am listening to my colleagues, I will drop a lot of the research because I know y'all are research people here. You want to see that too.
Thank you, Erin. And just to build on that, that also when people are concerned that there is violence happening, that to note that when people are moved into the family policing system, that is also a site of violence, particularly for queer and trans youth, for girls, for young women and gender nonconforming people. So moving someone from one site of violence to another isn't living into our commitment to do no harm. So let's build different responses, and that's part of the invitation here. Want to go now to Kebé to ask you the question about ways that you can imagine providers implementing and building support around these principles, particularly when it comes to what you mentioned earlier, which is leaving people alone if they come in with an adverse pregnancy outcome and just providing them the care they need, period. But what other calls to action do you have that folks can plug into?
Yeah, so I feel like my call to action is now listen to Erin. The call to end mandated reporting is the biggest one that I can lift up. I think that providers in their personal practice can better understand state requirements. A lot of reporting is happening when there's no reporting requirement at all. According to our research so far, and this is research led by one of our researchers, Lauren Polk, there is no law in any state that requires a mandated reporter to report a person who may have self-managed an abortion to police or to law enforcement. Providers can grapple with and make decisions around the huge discretion that they have, considering that the consequences of reporting to law enforcement from the cases that we've been able to identify, that consequence is overwhelmingly arrest, and also continuing to normalize and destigmatize and lift up that safe and effective abortion happens outside of the formal healthcare system all the time, and that people will seek follow-up care and sometimes seek emergency care, and there's no need to report them to police or to law enforcement, either for a suspected crime or for a suspected harm, right? As Erin just said, it doesn't increase safety. So what does exist is people's duty to protect that person's confidentiality and medical privacy. And like you said, the greatest support to someone is going to be able to give them, is going to be to give them treatment, to treat them when they show up in that setting. And I think just in terms of specific actions to lift up, we at If When How are providing training and technical assistance around mandated reporting. So if you're a provider and you want to contact us at info@ifwhenhow.org, and you're looking for support around fighting criminalization for self-managed abortion, you can contact us directly for that training and technical assistance. We also have fact sheets on mandated reporting around self-managed abortion and abortion criminalization. I can drop that in the chat. And we have also been doing a series on self-managed abortion, a webinar series. We started with a 101, we did self-managed abortion in the law, risk assessment for abortion support. Last week, we did abortion criminalization and care provision. And next week, we'll be doing self-managed abortion and gender violence, also directed toward providers and addressing some of these interventions. And we'll finish off with self-managed abortion organizing and advocacy. So Those are on Thursdays at 7 Eastern. And if you register for a future webinar, you can also receive the recordings for those that have already passed that you might be interested in. So yeah, those are the actions that I can share, and keep it quick so others can.
Thank you, Kebé. I so appreciate you and the work of If, When, How. I'm coming to Gabriel because the child welfare system and self-managed care are both sites of criminalization for trans folks, among others, so many others. So what are some actions you think that providers can take in this moment to implement these principles, and what calls to action do you have for them?
This is Gabriel. Thank you. And first, I just want to say that every one of those actions that you've already heard about is critically important for trans people as well. 1000%. You should take all of them that you've already heard about. Going off the conversation about the family policing system, I did want to point out that some folks in more progressive states are trying to do something good for trans young people by trying to pass laws that increase the likelihood of child removal and criminalization for parents who do not support their trans young people. I think that those laws are a bad idea for reasons that Erin and others have talked about, and more reasons that I won't bother getting into now. But I feel like that is one of the moments when we need to just stop and take a moment and reflect and think, is this actually what trans young people are asking for and needing? And is there a risk that we're going to make things worse? I'll also say that I was recently talking with somebody who got hired as a nursing assistant and was doing really well, really loved her job, getting all good feedback, but it was a provisional offer pending her background check. And she, like many Black trans women and Black trans and Black queer women, somebody who got arrested when she was the victim of intimate partner violence, and she ended up taking a plea and her job offer was rescinded. So if you are in a position where you are making hiring decisions, think about ways that we can get more people who've been impacted by these systems jobs. I also have a couple of specific other asks, some of which are also in the discussion packet. So one is that the Transgender Law Center has this program where they work with incarcerated people who are advocating for themselves for access to healthcare. And they are recruiting volunteer healthcare providers who are willing to look at their medical records and give them some advice, or maybe write an affidavit explaining what care they think the person needs. If you're willing to volunteer for that, I think it's an amazing thing to do. I'll also just say that in my work at the Transgender Legal Defense and Education Fund, we are almost always looking for healthcare providers who are willing to serve as experts in our cases, or who are willing to join amicus briefs educating the courts about trans health needs and debunking some of the myths. In fact, I can think of at least 2 opportunities to do those things right this minute. If you would like to help us with any of that, you can just write me directly. Also, so right now there are all of these efforts to try to ban trans healthcare. One that's happening right now is in Florida, where the Board of Medicine is drafting a rule to ban any form of gender affirming care for trans young people. There will soon be an opportunity to comment on the proposed rule. They have to read the comments and think about them, and the comments sometimes make it easier to challenge these rules in court. And healthcare voices are really important there. So keep an eye out, and when there are opportunities like that to speak up and support access to trans healthcare, please take them, and thank you for those of you who have been doing it already. I said that folks should write to me directly if you're interested in serving as an expert in a case where we might need somebody to describe why the healthcare somebody got in jail was not adequate, or if you want to sign on to a brief educating the court about trans health needs. Also, anytime you hear about something terrible happening in some state to trans people, the first thing that I recommend doing is finding local trans-led organizations, following them on social media and sharing their stuff and giving them some money. And one way that you can find those various wonderful organizations is by just checking out who the Trans Justice Funding Project has been giving money to lately. They only fund trans-led groups that are small, and they fund a lot of BIPOC-led and disabled-led groups in the South and the Midwest. And one of the things that some of those groups have told me is especially important is to think twice before you share the bad news on social media. There tends to be a lot of misinformation that can cause unnecessary panic and just make things worse for the people who are actually affected. So focus on messaging that is coming from the trans-led groups that are actually in the place where the thing happened. And then finally, this is something that similarly anyone can do, but I think it's always great to connect with people who are incarcerated. Black and Pink has a pen pal program where you can start pen pal relationship with an LGBT person in prison, which can do a lot to fight isolation and help people to stay connected to their communities. And last link I'll drop is just some resources if you are speaking out on trans health issues that might be helpful to refer to. Thank you.
Thank you so much, Gabriel. And I know folks have raised this in the Q&A that we're asking you to do this with the full awareness that healthcare providers have been under incredible pressure, trauma, exhaustion of the past 3 years, and also the defunding of healthcare that has been going on for many decades. And so we want to let you know that we're asking you to do this in community with each other, and that we have supports for you, and we want to build the supports you need and invite you into that process with us. So we're saying these things with love as an invitation to be part of a community to hopefully alleviate some of the challenges of implementing these principles. So with that, Dr. Perritt, what are the ways that you can imagine folks implementing and building support around these in the current context?
So actually, I want to start with a different response, if that's okay. And it's just an observation. I just want to make something that has been implicit, I think, throughout this this time we've had together explicit. And that's really to say just really clearly that we're talking about all of the different ways that criminalization shows up, right, in our healthcare system. But I want to be very clear that this has never been about the behavior. This has always been about the body, right? About the person. All of this criminalization is happening in the same body. And so we have to acknowledge that. We have to be clear about it. It's not about self-managed abortion. It's not about gender affirming care. It's not about any of the ways that we care for ourselves. Because if that were true, then we would not see such significant inequities in criminalization across demographics. So we know that this is rooted in a desire to eliminate some folks wholesale. And so we have to say that as often as we can. The other thing that I just want to acknowledge, and you mentioned in your prompt to this question, the challenges that many of us in the healthcare space have experienced over these last 3 years and certainly much longer. And I just want to be very clear that abdication of our responsibility to care is not an option just because it's hard or just because we're under stress. We still have an ultimate responsibility to care for our communities or to lead the work. If that is not what you're doing, you should not be doing this work. in terms of what are the asks, what are the ways that we can show up for our community? The number one way that I always lead with is simply stop calling the police. Stop calling the police on your patients. There is no instance where it is ever appropriate. There is not one single time where it is okay, it is acceptable, it is preferable, it is the desired outcome. It is not going to get us closer to health and well-being. It's not going to get us closer to healthy communities. It is not going to protect people from making decisions that you have decided are not the right one for them or their family or their lives. So just simply stop, and we'll put a period on that. The question though is like, well, why are folks, and when I say stop calling the police, I'm talking about all of the systems that are involved in policing. So this is not simply the sheriff that is down the hall posted up in your hospital. It's them too, but it's also the family regulation system. It's also all of the other systems that surveil our families. That is part of this carceral structure, the prison industrial complex, and we have to acknowledge those deep connections to healthcare systems. The reason why providers call the police on their patients are really twofold, is what is shown in the research. One, a desire to connect people to services. This falsely held belief that by calling the family surveillance system, that they will be looping people into care by reporting this positive urine drug screen, calling the social worker, then someone will magically get resources. That is not the way it works. There is no care in this system as it's designed. So, eliminate that as an option for you if you think that that is the outcome that you're seeking. The second reason is a fear of consequences for ourselves. If I don't call, then I will be punished. What we know is that largely that does not occur. People are not coming after doctors for not reporting positive urine screens, or not coming after doctors for not calling the family surveillance system or the police on patients. Kebé mentioned a huge amount of discretion that we have as healthcare providers. We are very, very powerful as individuals within these systems. And I saw a number of the questions that came up in the chat noting your positionality. I'm a medical student, or I'm a resident, or I'm junior in the team. You still have significantly more power than the person that you're caring for in that system. And you have to understand that and move in that capacity. And that brings me to the second call. Be brave. Be brave. We cannot continue to ask people with the most to lose to risk the most over and over again. And that's exactly what we're doing when we're saying, come seek care with us, and we may or may not call the police on you. Asking folks to risk the most, who have the most to lose, is not the way that we want to move through this. And so I'm asking that we be brave, we take chances, we leverage the privilege that we have in our healthcare spaces to create the kind of system of care that we want to receive when we seek that care. And to deeply, deeply listen. Listening is not something that we're taught in medical school. It's not. You were taught to talk, right? Because you are considered the expert in all of the things, in all of the rooms, in all of the times. And that's patently false. We are not the experts in this person's life and what they need. We may know the research, we may know the evidence. This person is the expert in their own life. We have to respect that. But the only way that you are going to be able to receive that expertise is if you shut your mouth. You have to be quiet. You have to listen. You have to make space for someone to show up when they are seeking care. And then, I think I mentioned this in terms of like how we use our privilege in these spaces. we spend a lot of time at Physicians for Reproductive Health doing congressional and Senate testimony, speaking with folks in the administration in the White House. I just want to be crystal clear. That is not how I want to spend my time. That's not why I went to medical school. That is not why that's not the way I'm going to pay off the $200,000 in student loans I still owe the federal government. Is not by traipsing around the halls of Congress. The only reason I am there is because of the privilege that all of the letters behind my name allow me. And so what we do organizationally in talking with and training providers around the country is to speak with them about the opportunity and the privilege that you have in this white coat with all of those letters behind your name, and to ask the question, when they give you the mic, when you have an opportunity, what will you say? Who will you fight for? Are you advocating for yourself? Are you advocating for your community? We have to take this seriously. And so my plea, my call to action is to understand the power that you hold. Do not minimize it. Don't downplay it. Don't believe the lies that they've told us about having to participate in this system. No is a complete sentence. You do not have to assent, consent, agree to all of the things are being demanded of you when you know that they are causing harm. I don't say that to say that there will not be a cost and there will not be consequences. There will be. There is always a cost to disruption, but the cost to disruption for the individual is not as great as the cost to the community by continuing to allow this harm to occur. We have to look at it as the long game. I'm so grateful for the opportunity to make my asks and happy to be a part of this.
Whew, Dr. Perritt, we're so grateful to you. You are, and you'll see in the chat, the embodying the spirit of these principles. You have been a driving force behind them. You have held us accountable to supporting providers in implementing them and to creating resources and materials for that, which we will share momentarily after Kara Page tells us how she believes that providers can stand in this moment in history and make these principles real.
Greetings all. I keep getting bumped, so I'm going to try to put my camera on. I didn't show myself earlier, but Kara, again, large afro, turquoise necklace, big what is it? Big glasses, brown coral glasses, and a quilt, Mexican quilts from Central Mexico in orange and purples and blues. I just want to say quickly, briefly, to respect everyone's time, I come through this work by way of being a healer and working with energy, earth, body-based healers and health practitioners that are looking at ways to build across false divides of what medicinal healing collective care strategies can look like. And I'm deeply moved by all the speakers in terms of how we are lifting up the agency of our communities, the agency of our families, of our people, to take it in stride on how we can create care strategies, collective care, and transformative strategies that center our safety and our well-being and our dignity. And so I do want to offer some examples of calls to action that I feel there's been a really powerful integration of reimagining what care looks like outside of just Western state private models of care, but also imagining the bridge between healthcare providers and frontline workers, social workers, therapists, and healers, and how we're going to move through an understanding of how we recreate and reimagine care, that what I call caring forth, bringing forth the water, carrying forward the water of our ancestral traditions, and not only imagining care looking like a Western-based model of care. And so one partnership, though I do want to name, sorry, I'm trying to say many things in 2 minutes, apologies to the interpreters, is that what it means for nurses, doctors, healers, birth workers, death workers, all the things, to take the risk to imagine care-based strategies that are deeply abolitionist and deeply transformative, while they are also risking their lives and their families' lives. And I want to give props and respect to Nurse Dawn Wooten, who fought for the safety and care of over 100 immigrant women at the Irwin County Detention Center in South Georgia. And many of us came together to organize and support a Black nurse who'd been working in a detention center and blew the whistle on a doctor that had been forcibly sterilizing and coercing women from all over the world. And then we organized with the Shut Down Irwin campaign, which is a huge coalition in the South led by Southerners, to work with the nurse Dawn Wooten for her safety, for the risk she took, while also working for the safety and care of the survivors of coercive sterilization, working with Kindred Southern Healing Justice Collective and the National Queer and Trans Therapists of Color Network and the Latinx Therapy Action Network to come together and provide care for the survivors in the detention center that were sterilized and the women who had left the institution. So just thinking about risk and what that looks like on a larger scale and what that looks like to hold risk and trauma response inside of our strategies that also reimagine what care can look like. And I also want to drop two other powerful networks of providers, one being the Equal Health Campaign Against Racism, doing global work. Healing Histories Project has been working with them to imagine how do you hold trauma for practitioners when they are holding the trauma of their clients on the front lines, because both things are simultaneous, right? It's not one or the other. There's a lot of risk that takes and bravery to reimagine care that is circular and collective. And then last but not least, I know we're tight on time, is REP in Minneapolis. Also, multi-care strategy rooted in an abolitionist safety frame that is calling on healers and different kinds of providers to build together, because it is the plan to keep us separated and not have us come together to reimagine care strategies that are transformative, rooted in liberatory harm reduction. Thank you, Shira Hassan, and definitely are pushing up against ideas of care and safety that don't repeat oppressive carceral state ideas of health.
Thank you, Kara. Everybody, please join me in thanking our incredible panelists. Thank all of you for staying for a whole 2 hours. We're going to invite you to stay for 5 more minutes so you can get plugged into this work and be part of the kind of collective care and resistance that Kara just described. So I'm going to turn it over to our brilliant Beyond Do No Harm fellow, Maria Thomas, and Fabian Fernandez, who is an organizer on this campaign, to tell you how you can get involved and the resources they've already created to support you in engaging this work. So stick with us for 5 more minutes. I promise you it's worth it.
Thank you so much, Erin. Actually, if you could just go back to the previous slides, and I'll take it from the top. All right, so we're going to skip this Menti for now. Maybe we'll share it as you all leave, if you would like to just imagine what non-carceral care can look like. And by the way, my name is Maria Thomas. I'm a light brown skinned South Asian woman with short black curly hair. And I'm so honored to be part of this work and so moved by everything that has been shared by our brilliant panelists and community tonight, and grateful that you are all with us. Erin, if you could go to the next slide. I think the one thing that we really want to encourage you to do is to go to our Beyond Do No Harm website. It's interruptingcriminalization.com/BDNH. And there you will see, organized according to principle, a lot of the resources that were shared tonight. And then at the very top of this landing page, you can download the principles and you can download a discussion guide that we're really hoping that you will be able to use in your organizing communities. I know so many of you talked about resistance that you're facing. And so this will be a way to build community, to grapple with the questions it sounds like you all are already thinking about. The next slide just gives a screenshot of what the principles document looks like. And the one after that, the slide after that, just gives you a look into what this discussion guide is and how to use it. It gives you prompts for reflecting on the various principles, some questions to maybe do a little research and interrogation on, ways to think about practicing and actually implementing these principles in community. And then, of course, we know that one of the things we really need to tap into to move towards that abolitionist horizon is our imagination. And so there's poetry and different creative prompts that we hope will allow you to kind of marshal different parts of yourself as we build the world we need. So the next slide just gives you an example of some of these reflection questions that you can engage in community. So, what does police presence look like in your workplace? And think about a time when having police in your healthcare facility caused active harm to someone, and what supports would have been helpful to prevent that harm. So we're encouraging you to kind of get deep into these questions, to think about what resources that are non-carceral, that are non-police already exist, and to lend efforts into strengthening them. Next slide. So this is actually a principle that came from some of the workshopping sessions we did with sex worker organizers and people in the sex trades around how harmful surveillance and gathering information and documentation that isn't relevant to a person's course of care is. And so we want to be thinking, and we want to be intentional about what are we collecting information on, and what do we need to stop collecting information on. Next slide. So these are just more screen grabs from the discussion guide, but please go into each of the principal pages to see the prompts around other resources, what you can do to read more and to feel supported and empowered, to be bold and be brave, like Dr. Perritt said, in community as we organize collectively. Next slide. And so speaking about collective organizing, I'm going to kick it over to my comrade and friend, Fabi, to talk about next steps in terms of what that collective organizing will look like for all of us as we go forward. Fabi, take it away.
Hi, y'all. I'm Fabian Fernandez. I'm a light-skinned Latino with some facial hair, a white shirt, and a chain with a white background. I'm a medical student and organizer with DPH Must Divest, which is trying to get the sheriffs out of San Francisco's Department of Public Health. And I have had the honor of working with Maria on these Beyond Do No Harm principles and many of the people here today. And what we've learned from that is that everything worthwhile is done with other people, as Mariam Kebé says. And we want to organize collectively to support you all in interrupting criminalization. And so there are two things you can do today that will help further this cause. One is if you are a part of a community group or an abolitionist formation or a professional organization, please consider signing on to these principles, and we'll add your name and your logo to the website. As an individual, we're trying to build a network. So if you sign on to the individual network thing, it won't go public, but it will help us connect you with other abolitionists in your area who are interested in these principles, and also to help us build out these principles together. What are the resources we need? What are the tactics we need to engage in? And how can we build a broad-based coalition to really interrupt criminalization? Because we need to be doing this together. So I'll pass it back to Maria, who can talk a little bit more about the mental health spaces.
Next slide. And I know we're at time, so I'll just say, look it up on our website under events. The next one is on November 15th, but we are committed not just to stopping the harm and doing no harm, but building beyond it. And so this is one offering that we have at IC that is all about workshopping and strengthening spaces where we can create non-police, non-carceral mental health response. And with that, I just want to take us to the last slide. As Fabi said, everything worthwhile is done with other people. And there have been so many people who have made this work possible. And we just have such deep gratitude to all of our Beyond Do No Harm Network members, many of whom are with us tonight and you heard from. We are grateful to our Cops Out of Care Network and our panelists tonight, Kara Page, Dr. Jamila Perritt, Erin Miles-Cloud, Kebé, Gabriel, Christine, and the whole team at IC, Andrea, thank you so much, Mariam, Fabi, Eva, Erin, who's been holding down tech tonight, Tiffany, Shira, Maurice, Louis, and Sheila. And then all of these graphics and everything on our website has been designed by Luna, who is just an incredible creative spirit. And then thank you to our access team, Krista Siguroa, who has been doing live closed captioning, and also to our Spanish interpreters, Jessica and Aldo, and our ASL interpreters, Glashanda and Sade. Thank you to the sex worker organizers, those who participated in the founding gathering at Sister Song, and everyone who is impacted by criminalization, who is at the heart of why we do this work, and to all of you, our participants today, and we hope to continue to build with you all. Thank you.
Thanks, everyone. And thank you, Maria, for all of your incredible labor to bring us to this moment and create all of these tools. And to you, Fabi, and to everyone who is still with us, including our access team and Erin, our tech support. Good night, everybody.